All right, so when we look at hypertension and diabetes, the role it plays, there are some things that predispose patients to both diabetes and hypertension. And I think in another presentation, I talked about the common soil hypothesis. And these include genes, insulin resistance, and dyslipidemia. All of these feed into the development of hypertension and diabetes, and that is why they are commonly comorbidities. And what we do find at the molecular level is we find atherosclerosis, endothelial dysfunction, and several abnormalities in the vascular tree, which lead to both micro and macrovascular disease, which cause cardiovascular problems. And that's why many of our people with diabetes, about 80% of them, will die from cardiovascular disease. Next slide, please. Next slide, because this thing didn't work when I pressed. Okay. So again, when you have hypertension and diabetes, what you do have is there is hyperglycemia, there is activation of the renin-angiotensin system. There is also activation of various cytokines which lead to immune activation, oxidative stress. You are moving faster than I am. And then inflammation. All of these lead to microvascular and macrovascular disease. Next slide. Again, here you see hypertension and diabetes, the way they work, and they affect both the peripheral vessels, they affect the heart, they affect the kidneys, they affect the brain. Next slide. So how does the patient progress from hypertension to heart failure? Many times we do not remember that patients who have diabetes, hypertension, their end stage is usually heart failure. So what happens is that a patient who has hypertension, usually they will develop left ventricular hypertrophy. And for those who smoke and have dyslipidemia, quite a number of them will also develop myocardial infarctions, which may be silent and unnoticed. Eventually, what happens is either a combination of diastolic and systolic dysfunction, which leads to heart failure and death. And this occurs over a few decades. But by the time the patient has started having heart failure, it is the beginning of the end for the patient because it's just a matter of months before death. Next slide. So what is the global impact of hypertension? We do say that diabetes is common, but even hypertension is much commoner. And as you can see that there are, in the year 2015, more than 10 million deaths took place because of hypertension alone. And over 200 million disability-adjusted life years occurred because of hypertension. And you can see the figures for ischemic heart disease, hemorrhagic stroke, and ischemic stroke. So hypertension has global impact. I don't think there is any person here who goes into his emergency room and will not see either a case of stroke or heart failure in the patients that are there gathered. Next slide. So this is looking at blood pressure control rates over the world. And you can see here that those who have blood pressure that is not well controlled, wherever you go, whether it's in Europe, whether it's in Africa, uncontrolled blood pressure is like 75% of the patients in most areas. Those who are well controlled are just usually single or small digits. Next slide. So up to 8 out of 10 patients need multiple medications to help reach blood pressure treatment goals. Up to 8 out of 10. Next slide, yes. And here you can see the various multiple antihypertensive agents which were required to reach goal in all of these studies over the past 2 to 3 decades. So you can see the number of, we'll say on average about 3 medications are required to bring patients to required targets. Next slide. And then this is looking at a study by Oji at Abuja, and is looking at the number of antihypertensive patients, that number of antihypertensive drugs patients are on. And you can see the large number, that quite a number of patients were on 3 or 4 antihypertensives. And since all of us here also manage people that have hypertension, I'm very, very sure that you do know that it is rare to see a patient who is controlled with just 1 antihypertensive. Next slide. How about awareness? And then those who are treated and controlled. Again, Odili et al. Showed the various amount of people that are aware of the condition. You can see about 60% are aware, those who are treated less than 50%, and those that are controlled less than 30% in most of the regions across the country. So he has looked at all the different geopolitical zones. So this shows you where we are. So it is similar to what we find in the rule of halves in diabetes, where you find that the more you look, the less you see. Next slide. So looking at the cascade continuum of hypertension control in Nigeria, you can see that 100% of the people who have hypertension, for those who are measured or screened, you can see the percentage dropping to about 85%. Those who are finally diagnosed, about 60%. Those who are treated, about 40%. And then those who are treated to target, less than 20%. So again, this is like the rule of halves that we see in diabetes. And you find out that the number of people with any NCD that are actually treated to go are so much smaller than the number that actually have the condition. So even if you are able to control that tiny percentage, you're only managing a fraction of the total disease burden. So this slide is showing us that a single pill combination of antihypertensive agents is associated with better adherence and control. And you can see that, that when you have a fixed dose combination, you have better compliance. And the reason for this is very obvious. Some of our patients have to swallow 10 to 15 tablets per day. So when you are able to combine some of them, you find that compliance is much better. So 21% better adherence is seen with patients on single pill combination. So where you can combine them, please do combine them. It's not fair for you to tell your people with diabetes to reduce their food and increase the tablet, because now the tablet is competing with food for space inside the stomach. And when the tablet load is more than the food, I'm sure you know the patients are not likely to comply. Next slide. So we will be talking now concerning sacubitril valsartan, which is Euperio. I'm sure quite a number of us have come across it. Either the cardiologist referred the patients to us with it, or we have prescribed it. And what this combination of drugs is that it looks at simultaneous inhibition of neprilysin and suppression of the reticular, the renin-angiotensin system. And it shows that it has complementary effects. First of all, you have the effects of sacubitril on the natriuretic peptide system. And then we have the valsartan, which has effect on the RAAS system. And this eventually leads to synergistic effects on the patient. So you are taking care of the natriuretic peptide system, the sympathetic nervous system, and the renin-angiotensin aldosterone system. Next slide. In the angiotensin-neprilysin inhibition versus enalapril, so this is looking at sacubitril versus an ACE inhibitor. The conclusion was that, if you can see it, let me see whether this thing works here, that, please go back. Yes, you can see that the sacubitril was superior to enalapril in reducing the risk of death and hospitalization for heart failure. So that is what this group of drugs does. Next slide. So what is the evidence to see that this sacubitril and valsartan is actually better than enalapril? There are studies that have shown that when you use enalapril versus when you use Euperio, you can actually reduce the risk of hospitalization for heart failure and cardiovascular death. And that reduction is in the nature of 20%, which is very, very significant. We used to rejoice when we were able to reduce morbidity using the ACE inhibitors, but now we have gone much further by combining the ANIs and the ARBs. Next slide. So what is the effect of neprilysin inhibition on renal function in patients with type 2 diabetes and chronic heart failure? This is looking at the paradigm heart failure trial. And I will just go to the conclusion so we can save time, which says that in patients in whom the renin-angiotensin system is already maximally blocked, the addition of a neprilysin inhibition attenuates the effect of diabetes to accelerate the deterioration of renal function that occurs in patients with chronic heart failure. So it's not enough to just block the RAAS system. It is better to use Hyperio, which has both neprilysin inhibition and RAS blockade, because if you do a RAS blockade alone, you'll find that quite a number of the patients try to compensate on the other side of the natriuretic peptides. Next slide. Next slide. Okay, let me try again and hope we don't move it at the same time. Okay, it's not working. Next slide. Chairman, you see, it's not my fault. They are taking some of my time. So now you have lost me. Have you gone forward too much? Please go backward. You have moved. I think this is where we were before. Yes. So this is looking at heart failure and cardiomyopathies. The influence of Hyperio on glycemic control in patients with type 2 diabetes and heart failure with reduced ejection fraction. I'm sure many of the endocrinologists here, you are having to learn new terminology in terms of HFRF and HFPF and EF and all the different Fs. It's just because diabetes and hypertension now are getting more and more closely related. So you cannot manage hypertension without managing diabetes and vice versa. So this study looked at the influence of this sacubitril valsartan on the glycemic control of patients who had this. And the conclusion of the study is that patients with type 2 diabetes and HFrEF who are enrolled in this study and received the trial drug, they had a greater reduction in HbA1c than those receiving enalapril, despite minimal effects on fasting plasma glucose. So it suggests that not only does this drug improve cardiac function, it also improves glycemic control, which also gives it an added benefit. So you're adding an antihypertensive that does not reduce glycemic control. We do know that many antihypertensives have a negative effect in terms of poorer glycemic effects on patients. Next slide. So this transition study looked at the initiation of the sacubitril valsartan in hospitalized patients who had HFrEF after hemodynamic stabilization, and it was a randomized trial of pre-discharge versus post-discharge initiation of the drug. Next slide. And what were the key questions inside this study? The key questions that can this trial drug, sacubitril valsartan, be started after an ADHF event? And then also, could the target dose be achieved in about 10 weeks? And this is still part of the paradigm HF patients who are ambulatory at the time of inclusion. So the transition study aimed to provide evidence on the safety and tolerability of the early initiation of Hyperio in HFrEF patients. And these patients were stabilized after a major episode. Those that had pre-existing or newly diagnosed heart failure were included, and those that were on any ACE inhibitor or ARB before admission or ACE ARB naive. Next slide. So the primary objective was to evaluate the proportion of patients who achieved the target dose of 200 milligrams BD at week 10 post-randomization, and assess the proportion of patients who achieved and maintained the dose of the trial drug at that time, 100 milligrams and or 200 milligrams BD for at least 2 weeks, leading to week 10 after randomization. What was looked at was the secondary objectives were to look at whether we could achieve and maintain any dose for at least 2 weeks leading to week 10 after randomization, and those that were permanently discontinued from this combination due to adverse effects during the 10-week treatment period. Next slide. So a subclass of the patients, those that had diabetes, was also looked at, and the outcome. So when you look at our group, the one that concerns most people in the room, diabetes, we find out that when the patients were titrated, the p-values show that there was a significant number of patients who had diabetes, that had these comorbidities. Next slide. So what are the primary and secondary endpoints? Pre-discharge is the color in blue, and the lighter one is the post-discharge. And you can see that the drug was well tolerated across all the different doses, and those that had to actually discontinue the drug due to adverse effects were very, very small. Unlike when we were using the traditional ACE inhibitors, where plenty of patients had to discontinue drug because of side effects profile. Next slide. So in conclusion, comparable proportions of patients met the primary and secondary endpoints, and about half of the HRAF patients were stabilized after an event, and they achieved the target dosage of 200 milligrams sacubitril and valsartan within 10 weeks. At week 10, more than 86% of patients in both groups were receiving any dose for a longer period of 2 weeks without having to interrupt it. So this shows that this new combination of drug does not have any significant adverse event that will make the patient discontinue the use of the drug. So it is quite tolerable for patients who have diabetes, just like patients who have other comorbidities that occur with the heart failure. Next slide. So putting all of these together, we have looked at the effectiveness of the drug, we have looked at the effect on glycemic control, we have looked at the tolerability, we have looked at the effectiveness in reducing cardiovascular events. So putting all together, this study here shows that the enalapril patients compared to the euperio patients, there's a 20% relative risk reduction of cardiovascular death or first heart failure hospitalization. And that is very, very significant when you have 20% reduction. And this occurred within just about 3 years of use of the drug. And then when you look at the reduced risk of first heart failure hospitalization, it was actually even reduced by 40%. So this is a game-changing drug that is able to reduce patients' morbidity, give them new life, so that they can have hope that the heart failure is no longer a terminal condition. Remember the earlier slides I showed you that once patients start having heart failure with diabetes and hypertension, you can count their end in months. But when you look at this, you see that within days, the patients have experienced great improvement. So there's a 20% reduction of cardiovascular death or first heart failure hospitalization, and then a 40% reduction of hospitalization within 30 days of starting this drug. And then also in those who are hospitalized for HF, RF, EF, you have 38% of them having fewer 30-day heart failure readmissions, and then 29% fewer patients hospitalized more than once for heart failure. So it shows that the effect of this combination of sacubitril, valsartan improves the patient's health, the patient's longevity, the time out of hospital, glycemic control, and then cardiac function, amongst other aspects of the patient's cardiometabolic profile. Next slide. So the HF-ref patients treated with Uperio were significantly less likely to be hospitalized multiple times. As we have demonstrated, 30 days post-discharge truly matters for your patients. Heart failure hospitalization is a critical time to reevaluate chronic heart failure treatment in appropriate patients. Uperio has shown the ability to reduce 30-day and recurrent readmissions. In the US and other places where physician KPIs are measured, your readmissions usually are a major factor that will say whether you have reimbursement, because if you are readmitting a particular patient, it means you are not really doing too well. Congestive heart failure patients on standard therapy may be more receptive to treatment change following a heart failure hospitalization, and the hospital provides a well-equipped environment for treatment modification. So when we reduce hospitalizations and readmissions, obviously we are going to reduce patient expenditure. We are also going to improve bed space availability, and then we'll be able to meet our key performance indices in terms of the quality of care we are giving our patients. Next slide. So this is looking at a comprehensive set of data on the effects of Uperio to reverse cardiac remodeling. And these two studies we'll look at as the Evaluate HF and the Prove HF, which is looking at the effects of angiotensin receptor neprilysin inhibitor, otherwise known as ANI, on cardiac reverse remodeling. It's a meta-analytic study. Next slide. And what were the key messages of these studies? I've tried to compress many of these studies. We didn't go through all of the slides available just to save time. And these two new studies show that the treatment with Uperio leads to reverse cardiac remodeling and improved pumping function. And these two new studies complement the Paradigm HF and the Pioneer HF and provide evidence on the mechanism through which Uperio delivers superior outcomes versus the traditional ACE inhibitors, which were the top of the pack in the past. And in the Evaluate HF, Uperio initiation leads to a rapid and significant improvements in echocardiographic measures of cardiac remodeling as early as 12 weeks. Remember that the events that lead to this cardiac remodeling takes several months or years, but this is a drug that is able to help the patients very early at 12 weeks. And the Proof HF further confirms that the treatment with Uperio leads to significant reverse cardiac remodeling and improved cardiac pumping. So if you do your echo for the patient at the beginning and you go and do the echo 3 months, 6 months later, you can see evidence of improvement. So there is improvement in cardiac structure, there is improvement in cardiac function, and then this has led to a significant reduction of NT-proBNP as early as 2 weeks, and this is sustained in the study as long as 12 months and beyond. So in the Proof HF, these studies are consistent among all the different subgroups. So you can see that this is a combination of medication that is able not only to control blood pressure, improve renal function, improve cardiac function, reduce hospitalization, and then actually reverse the negative processes that are associated with diabetic cardiac modeling. Next slide. So a meta-analysis of all available studies to date confirmed that Uperio consistently led to reverse cardiac remodeling, improve cardiac pumping function as compared to the traditional ACE inhibitors and ARBs, which we used to use in the past. And patients with Uperio have shown significant improvements in all the parameters. And we should remember that it has a rapid therapeutic effect within just a few weeks. and that these benefits were greater for patients treated as early as possible. So you don't need to wait for the patient to leave hospital. You don't need to wait for the patient to come for 2 or 3 clinic appointments before you put them on this drug. So it is the first-in-class ANI for the treatment of patients with HF-RAF that improves outcomes versus an ACE inhibitor. So we are moving to the next frontier, the next level. We are moving from ACE inhibitors or ARBs to Euperio, which is a step further in the right direction. It's available in different doses because some patients have a higher blood pressure than others. So you have doses from 50 all the way to 200 milligrams BD. So if you've not prescribed it or your cardiologist has not prescribed it, please remind them that there is something that they can do. So in conclusion, diabetes and hypertension are common non-communicable diseases. They lead over time to cardiovascular changes, renal changes, and eventually to heart failure. So when we look at kidneys, we talk about end-stage kidney disease in the heart. We see heart failure as the end stage of the cardiovascular problems the patients have. And this eventually leads to cardiovascular morbidity and mortality. And before, we used to think that it was something that you could not stop. But with what we are seeing now, you can see that this is a cause that you can actually truncate. So a key pathway in this downward spiral to mortality is the activation of the RAS, which this presentation has shown a novel way to block, and also we block the overcompensation that occurs through the natriuretic system. And you can therefore restore cardiovascular health. Sacubitril and valsartan synergy provide a novel method of preserving cardiovascular health that far exceeds ACE inhibitors or ARB alone. And I recommend it to all of us so that we'll stop losing our patients to the morbid anatomists and also to the cardiologists. So these are the references. You can read them so that you too can educate yourself. I was happy when I was giving this talk because I didn't understand the pathophysiology very well, but with this, I am now very, very educated, and I'm going to continue to give more patients opportunity of this drug. Thank you very much for your attention.
A round of applause for Professor Flasamade, just on top of the time.